So it's V31 Phaeochromocytoma. A 40-year-old man referred to your clinic with hypertension, headache, and palpitation and sweating. How will you investigate him? I don't know whether I'm sitting in the medical outdoor or surgical outdoor. This sound like it could be phaeochromocytoma. So I would take a history, looking for any specific symptoms like headache, dizziness, palpitation, ask about family history. The symptoms are classically paroxysmal and they are exaggerated by trauma and stress. Phaeochromocytoma is seen in men 2A and 2B syndromes and neurofibromatosis, von Hippel-Lindau syndrome, and SDH mutation. I would perform a full examination to confirm the diagnosis with the blood and urine analysis. How is this diagnosed? So there is some guidelines by Endocrine Society in patients who have these symptoms should be screened for phaeochromocytoma. So these are quite a lot. So someone who has signs and symptoms of phaeochromocytoma, someone who has unexpected blood pressure response to the drug, surgery, or anesthesia, someone has unexplained blood pressure variability, someone has incidentilloma, uncontrolled hypertension, previous treatment for hemochromosoma, or hereditary risk of phaeochromocytoma or paraganglioma in the family, or syndromic features leading to the phaeochromocytoma-related hereditary syndromes. So initial biochemical test will be either plasma or urinary metanephrines. What radiological test confirm the diagnosis? So CT is the first imaging, and if CT is not recommended in the patient, then MRI can be done. CT has sensitivity at more than 90%, but specificity is very lower. So it can be, that's why MRI is better in detecting extradural tumors. But it can be improved by specific imaging characteristics such as the density, contrast enhancement, and contrast washout. Functional imaging provides a higher specificity. Anatomical imaging and is recommended in cases where there is suspicion of multifocal or multi-disease. So functional imaging is number one is iodine 123 MIBG scan, 95% specific and sensitive, and then other is F-Dopa PET, which is used for detecting metastatic deposits or multifocality. When should genetic testing be undertaken? So genetic testing should be at least considering all the patients and strongly in specific patients such as those with us previous positive family history of PPGL or carriers of tumor susceptibility gene mutations, and those with the syndromic features or metastatic disease. Why do patients get symptoms? So mechanism, medulla secrete a lot of catecholamines which act as alpha and beta receptors, causing hypertension, tachycardia, and hyperglycemia. 10% tumors are bilateral, 10% are extrarenal, and 10% are malignant. What pre-op steps should be taken prior to the surgery? So all cases should be discussed in MDT and medical preparation to decrease mortality and morbidity. All patients require comprehensive cardiac and anesthetic evaluation. Alpha blocking should be started 7 to 10 days before with phenoxypenzamine and doxycycline until postural hypertension occurs. Then you can start the beta blockers, and don't start beta blockers together or before. It can give hypertensive crisis. So what is the surgical approach for the removing the phaeochromocytoma? So there are two approaches: transperitoneal phaeochromocytoma removal, transperitoneal laparoscopic approach, or retroperitoneoscopic approach. And if it's bilateral, then partial adenectomy can be considered. There should be, during the operation, there should be minimal tumor handling. Once the tumor is devascularized, the sudden drop in the catecholamine level, then patient may become hypertensive. So patient needs a lot of volume replacement. And you should keep updating the anesthetist during your surgery on each step. Post-operatively, the blood glucose should be monitored. Severe hypoglycemia is common due to sudden removal of the glycolytic effects of the secreted catecholamines. The phaeochromocytoma, the renal gland scoring, this is for pathologists depending on the PAS score, phaeochromocytoma adrenal gland scoring system. If it's less than 4, benign; more than 4 suggest it's malignant. And annual follow-up should include a medical history, proper blood pressure measurements of the plasma or urinary fractionated metanephrines. Thank you.